we have a high level of obesity, we have a high level of diabetes, we have a high level of hypertension, cholesterol, and all of this shebang, then we are a ticking time bomb. So can the system actually cope? That is how the industry is designed.
Oh my God, the healthcare industry is just... the country has announced, the health ministry has announced that they will be receiving the Mpox vaccine soon. Are these viruses, the Mpox and COVID and all that, are these viruses man-made?
The damage is done.
Okay.
So even though we can cry, weep and everything, you can see the public outcry. You could see that. You could see the response today. And today, the biggest problem we have is the distrust and the trust loss.
Feel ni pancreatic cancer
Bersama saya Dr. Roland
satu benda yang one of the worst stress can happen bila you makan tak sedap.
Doktor, saya punya culture kena makan nasi.
Zaman moden that every second of your life you either earn or learn.
Batu Medic Show.
Hey guys, what's up? Welcome to another special episode. This one is a joint episode between TheGoodCastShow and Lesungbatu Medic Show. That's right. This is an episode that's been a long time in the waiting, a lot of discussions, and after I think 1 year, we are finally here. So my guest today is of course, the proprietor of his own podcast show called Lesungbatu Medic Show. His name is Dr. Roland Victor. He's a medical doctor cum influencer in Malaysia. He's a general practitioner with key interest in hormones, especially men's health. Having completed his medical degree, he pursued his master's in public healthcare management. He's been in practice for over 15 years in both government and private practice. He's a key resident medical doctor at the KL Sky Clinic, KL's first lifestyle and wellness clinic situated at the Soho Suites, Kuala Lumpur. He believes that preventive medicine is the only way to move forward in keeping people healthy. Prevention is better than cure is his motto. And also, if you guys have not known him enough, you can follow him on TikTok, and he's a very controversial doctor, an opinion one, and I'm sure today we'll be sharing a lot of very spicy topics regarding Malaysia's healthcare industry. So welcome, doctor. How are you?
What's up, Vino? I'm good.
Good, So let's get to it first. I want to talk to you about private care.
Yep.
Hospitals, okay? So recently, our health minister Zulkifli Ahmad, he says that private hospitals should shift from pay for service to pay for outcome to improve health outcomes. Now, of course, as we all know, medical expenditure is very high in Malaysia. Just to give a perspective on that, medical inflation rate in Malaysia is 12.6%, which is much higher compared to the global average of 5.6%. So I want to ask you, doctor, as a person who's worked in public as well as private space, has private healthcare gone out of control from the perspective of cost to the patient?
I think if you're looking at costs, I think it's more than 12.5. I think it's almost hitting 18.
18.
I think.
My goodness.
Because stats can be a bit deceiving that comparative to the way that we are looking at what's happening when you walk into a private facility or when you go into a private hospital. You see how the bills just pop up.
Yep.
And looking into when what we looked at is whether it's business oriented or patient oriented, I think we need to strike that balance. Of course, we know that there are certain acts like the Private Healthcare Facility and Services Act where there is a control of fee regulation in terms of procedure. That means how much of fee does a doctor receives during his service in a hospital. But the other inclusions will include like registration fee, nurses fee, and your food maybe will be coming like a 5-star kind of restaurant service for you. You will have to pay that. Your towels and stuff like that.
Even though hospital food is nothing close to that.
So maybe you might pay for the bed for a certain price, maybe 200 ringgit or 150 ringgit or 250 whatsoever. But then there's also a lot of frills that are included. And that's what creates the bill that just blows out of proportion. So what I see that is just like, we need to go to a perspective of there is some form of audit going on in terms of fee regulation. And maybe insurance companies, they need to have sort of like an undercover operation also in order to curtail misdiagnosis or overdiagnosing. So when something can be mitigated in a minimal fashion, you get thrown into a CT scan, you get thrown into an MRI, you get thrown into wondrous kind of medical equipment just because we have it. And just because we feel that maybe we'll find something new when we send it into a machine. But when we look into government healthcare or public healthcare, I think we are sometimes able to mitigate or diagnose with the bare minimum equipment and tools or diagnostics and get the same outcome. So
are you saying that private healthcare's motivation is profit over people's safety?
Definitely. I mean, you cannot deny that they are a profit-oriented business. I mean, it only runs in that. You just look at the amount of ability for them to scale up with new hospitals, look into they are present in the stock market and whatsoever. So they have to report to their shareholders. They have to report to their owners and show like there is some form of profitability. If not, means you won't see that much of private hospitals, clinics, dialysis centers mushrooming at this very moment.
So are you also saying that it is more profitable for humans to be sick as opposed for us to be in good health for the industry that you are part of?
I think that's a wrong way to look at it. I think there's also profit in the way to prevent disease and management. What I mean to say is like if you are able to move the industry too much towards wellness, then you see less sick people, but the cake then moves towards preventive medicine. People investing into better food, people investing into better work-life balance, people investing into exercise, people investing into regular checkups, rather than, I'll give you a scenario. Let's say you're going to spend maybe 80,000 ringgit for a procedure. Sure. Maybe let's put it a bypass. What if you're able to spend like 2,000 ringgit every year for a very decent medical checkup? So the issue now is like, look, are we able in a government setting spend 80,000 ringgit, even though you're going to pay a bare minimum of maybe 200 or 300 ringgit when you walk in to do a procedure in a government setting because it's all subsidized, where your tax would have contributed in that way, or you can ease down and give reward-centric tax system where people are able to spend money into this segment of businesses, rather than just looking at just like full-on tertiary medical care, surgery, operations and stuff. So that's one thing to look at. So I feel that the spending is still going to be there. It's just where it's going to trickle down to.
And do you think, what's your opinion of IJN's recent request for the 40% hike, which they are now, I think they are currently, I think MOH has said that they want to meet them and discuss them. What do you think about it?
Okay, it's a very, very good thing that you pulled off. And when I look at it, like, I feel the need for the increment is somehow necessary.
You do?
Yes.
40% higher?
Definitely. Because maybe IJN has been operating with a bare minimum fee towards it. Because you go back to the history that the entity that owns it is the Ministry of Finance. And it's all technically a government entity. But I'm not too sure like how the whole tax system or how the organization structure is. What if KKM were to buy back IJN? First thing to think about. Or they would pass it to the Ministry of Health at goodwill. But I think here in this perspective that it's definitely a cash cow to them also.
Yeah.
To the MOF. So they don't want to let it go just like that. And when we look into the facilities or cardiological facilities in KL, the reference center is now Serdang. And Serdang is overloaded. So if it's going to go out from MOF, and MOF is going to use budgets coming from the government. So what if you roll it back to KKM and increase KKM's national budget to handle cardiovascular issues? Then you also have technically like 2 centers to facilitate 5.7 million people in Klang Valley. So you have technically 2 centers to go along, because if one has heavy traffic, because the traffic at the moment in Serdang is like maybe for a bypass you might be waiting for at least a year.
For a bypass?
You're going to wait. So now this is where the problem comes when I see the big issue. So you have some people who have passed that gate of no return. They have hypertension, cardiovascular issues, diabetes and everything. And maybe they're in their 50s and they need a bypass. And when you go to these centers, they say, fine, we'll do it for you, but you got to wait. And now what is the option? This person is not a government servant where they can maybe roll back to IJN and then sort of paid for, or you are just maybe an entrepreneur who maybe don't have the ability to raise like 80,000 straight, and you don't have a medical insurance, so you cannot access other private cardiologists outside there, so you're stuck 1 year in waiting. And maybe in your situation, maybe you have like 200% blockages and you're running on one vessel. So what do? Are you able to be a good breadwinner at this point? Your ability to work full on operation, maybe you run a SME, it's all gone. So now how would I look at that, the social economic contribution also? That's also one big thing to look at in healthcare. We cannot just be a physician just looking at just health. We got to look at the bigger context of how this whole thing works into our social economic construct. So yeah, I would feel that in my perspective, if they could actually get the books cleared, there's a buyback. Everything goes into one central control. So just like how maybe we had like the Institute Cancer Negara IKN in Putrajaya is fully managed by KKM and everything. I think IGN maybe can go into that part.
That way.
Get back. Because now what we see is it's sort of like for business entity, and there is this small heart towards fallback if government servants or they want to go to the service, okay, we're going to pay back. Or if KKM cannot manage that specialization or certain demand for certain procedure, okay, IJN will take it and they will pay IJN for that. But this, what I'm saying is, so will also roll back to something which has to be done very, very soon. I think we wasted a lot of time, is to go into a health financing system. So this is just like a small cog in the whole healthcare system. But health financing system will be something that we cannot neglect anymore already. It's already due time. The 1 ringgit, 5 ringgit kind of services that we're looking at is not going to be relevant. It's not relevant anymore because we are not even at 5% or 6% of our GDP in terms of health spending. We're now only at 41. Maybe as we speak, when the budget is approved, maybe we're going to get 46 or 47 billion maybe. But that's how much of people who are sick. So when we have so much of the public that require healthcare services, we have a high level of obesity, we have a high level of diabetes, we have a high level of hypertension, cholesterol, and all of this shebang, then we are a ticking time bomb. So can the system actually cope? If the system is not able to cope, and you have a rising B40 moving to a B50 to a B60 situation, and a lot of subsidies has been removed and stuff, so are these funds going to go into a different segment? If I give an example, like Singapore, if they even in their CPF system, you are actually able to claim for medical services and benefits. But back in 2012, when I was serving in the Ministry of Health itself, there's a lot of discussion prior to GST about coming up with a health financing system, where that means how per queso works. You need to have a national health system where you sort of get a minimum. Everybody has to have some form of insurance policy. I don't know how they're going to do it today because it's government, and maybe there's people who have their private insurance, or maybe they have sort of like a kickback from their income tax. They have to be very creative in this. And at least to protect the lower bracket. That means that they too can actually access private facilities and also government facilities where it's deducted from the system. So that coffer is sort of like a lock coffer. There's always fund inside. Like if you look at how sufficient the per queso funds are, or even KWSP, very sufficient. I mean, they're able to go out, invest, create. And that kind of funding will also allow to mushroom more facilities or more healthcare kind of segments for the public.
Definitely. Now, speaking of what you said just now, you talked about the waiting period for a bypass. So that's obviously our one thing that has to be said. Our public healthcare is definitely affordable, definitely.
Yes.
But of course, there is now a huge overcrowding issue that I think even our health minister has talked about recently. How would you go about solving the overcrowding in our public hospitals?
Okay, this cannot be solved in one term of a minister itself.
Yeah.
I think they really have to look at maybe a 10-year, 20-year pipeline project. Where the first thing is, like I said, there has to be a lot of triage going on now. I think the people who pass a certain age group, maybe in the 40s, 50s, who have certain chronic issues, then we need to make sure that they are closer towards the surgery than the younger ones.
Yeah.
So like certain bills passed, like the latest tobacco bill being passed, stopping younger kids from having access towards tobacco or electronic cigarette and stuff like that, is a good thing because we know these things are a problem. So we need to make sure like the younger age group also do not contribute to the problem. First thing.
So what you're talking about is more preventive.
We're looking at the younger age groups have efforts being looked towards them.
Okay.
That means either looking at national kickbacks or government or private incentives towards companies and making sure that they get to go for screenings. And with screenings, we capture certain issues at the early things. So it's easier to nip off or reverse or recover issues. Maybe you've got kids having obesity. You have younger adults having hypertension. You have younger adults with pre-diabetic situations. So you're able to reduce the risk immediately. Look, you are in this capture, in this cluster. We need to put more effort. We need to have more education towards the preventive and try to sort of provide some sort of reward system also, which they can actually pick it up. They can actually feel there's some reward, or even have this clinic kesihatan and everything, or even like GP clinics and all, to be subsidized to work on this project. For example, I just give you a simple scenario. Even 10 years ago, when I was in ministry, there was one project that we wanted to do in KK Jinjang, which actually sees like 1,000 tickets a day. The clinic that sees almost 1,000 numbers.
Wow.
Probably maybe it's higher now. And we wanted to diffuse the number of people coming in for diabetic and hypertensive therapy, to diffuse it to 30 clinics around where we will pay the clinic like a minimal fee of 10 to 15 ringgit, just based on the fee schedule at that point, to see them every 2 weeks or 3 weeks or a month. And the medications will go automatically coordinated. That time was only post Malaysia. Now you have all the kinds of services. They send the medicine to them. So the doctor there in the private clinic would see the patient and he would be paid by the MOH. But by the time, I don't know whether the project took place because I already left already by the time. But I was working on the project. And it looked like, can you imagine if I'm able to take out like at least 100 patients or 200 patients from that traffic? That means that the clinic kesihatan is able to see maybe they can spend more time, spend more quality on the patient. It's not going to be this 3 minutes, 5 minutes, like, okay, I've got the reading. We are only seeing numbers there and we're trying to up the medication because there's no time to actually interact and say, like, what's going on? Why is hypertension? Are you going to an emotional crisis, or it's work stress, or it's just your poor diet because you are in a such scenario? Because we need to listen to our patients. The biggest way to treat people is actually to listen to them and then decide what we need to help. But unfortunately, because when you have that much of traffic, you just want to clear the numbers.
Correct.
So this is what happens even when you have too much of patients, even in private sector. So you have like one doctor who's really, really famous and everybody is lining up to see him. And then it becomes a money operation really. Because like, look, I have to clear these people. They have to see me and I'm only able to give them a small amount of minutes to be seen, and then I got to make a decision. But in certain Scandinavian countries and all, maybe some doctors actually work sort of like pilots. You only can clock in 100 hours.
Wow.
So that means like I cannot do more than that. But that only will come if you have a healthier population.
Correct.
then we can translate quality. So it's not about how much you earn. It's like you will earn based on how much of quality you can provide, rather than how many numbers you can see.
But on that point, is the reason why we have a population that is not healthy. And of course, now I think they recently announced they proposed, I don't know whether it's confirmed or not, but they're going to introduce a tax on drinks with sugar, carbonated, I
10
think
cents.
10 cents or 50 cents, I think.
Yeah.
So is the fault here on our government and especially KKM? Because if you look at countries like China, for example, I mean, before that, I've always felt that the doctors and medical fraternity never ever treat a condition. They always treat the symptom. That's the number one goal. If you are sick, you go to a doctor. If you have a fever, their goal is to break the fever. Very few doctors say, "Hey, it's okay. It's just a fever. It's your body's natural response. Leave it. It'll be fine. You'll be fine." No, they prescribe you Panadol or something like that. Antibiotics. That's the quick one, lah. Straight antibiotics. Now, if you look at China, for example, and this is why I respect China in this sense, because they look at the human condition from a holistic matter. They have even now used facial recognition to actually stop children engaging in online gaming after 10 p.m.
Wow.
They have done restrictions on social media so that people will sleep earlier, right? So they're looking at that aspect. The sleep is so important, how the blue light affects your sleeping patterns and all that. We don't do that. We wait. Once we are more of a reactive nation as opposed to a proactive one, right? Like what you believe is preventive. So is KKM complicit in this? Why the nation is so unhealthy now is because nobody does advocacy campaigns. And even if it's done, it's small. It's very, very small scale. It's done maybe they have one day where it's a national day or whatever, and then they do one booth there. That's it. It's never done in schools. Schools, remember when we were young, you used to have all those Milo vans coming in and all that kind of stuff, which promotes sugar. But do you think
Now only
KKM
we
is,
realize it.
now after how many years? But do you think KKM is not doing enough, and that's why our society is so unhealthy?
Okay, I think I cannot blame KKM on that. I think it goes back to discipline. So when you use the reference of what China is doing, say, then it also comes to infringement of the freedom of choice. That's another big thing.
Yeah.
So if you look about the 10% sugar reduction, I don't see it having any impact at all. But honestly, I think maybe in the budget, I think some form of sugar tax is still going to come in. They're going to increase the excise or something like that. Will sure happen again. But now look at this. When you were telling people like for 10 cents you're going to have like no sugar at all. So if I had just like a little bit of sugar, would that be? Would I get a 10 cent reduction? No. But maybe I don't have a problem with diabetes. Why can't I enjoy my teh tarik? I mean, I'm going to be as right as I can. 2 weeks ago, one of the newspapers put out an article showing that Malaysians are spending between 70 to 100 ringgit a week on beverages. And I'm not talking about like a mama shop kind of 2 ringgit, 3 ringgit. I'm talking about premium beverages and if you also see the number of these beverages companies mushrooming and investments that they're getting, it shows that, look, here you're showing that we have a health crisis. Here there's so much of people interested to dump money into such products.
Yeah.
So what I see is like, look, the industry is just a layer on layer. That means like, look, we will open up as much shops as you wish, but we will also open up more hospitals because we know we will create one problem and there's another problem to solve. When I see that 10 cents issue, one thing I think most likely next year I'm going to put this idea out is this concept of having half rice.
Okay.
You see, if you go to the shop, to a chap fan shop or nasi ayam or whatever, maybe it's a nasi campur shop, you will say like, okay, if you're cautious a bit with the rice, right? The guy's you're going to tell him half. I want half rice. But if you don't say that, it's going to give one full cup of rice to you. But that cup easily will already contain about at least 300 to 400 calories. Not even deciding on what kind of grade of rice it is. So they're going to use technically the lowest grade, high in starch, standard, because it's business. So imagine if you have something initiated by the government telling like all shops from today is going to serve a fee of half rice, which is going to be 50 cents less or $1 less, means like standard rice, 2 ringgit. Half rice, 1 ringgit. Every shop have to do this. Immediately, the 10 cents, now it's 1 ringgit. It will have an impact. And you have a choice now. I want half rice because it's a standard thing. Everywhere gets to have that. You have, in terms of your protein, everything, there's no discount to that. But rice, you got to go down. Because words have power. And the definition of sweet or sugar has been misunderstood. Because when we think about sugar, we only think about sweet drinks. We think about our coffee, our teh tarik, our cendol, only this. But we do not think about complex carbohydrate, which is starch, rice, flour, pastry, all of these things can be managed. And being rice as our staple food, right?
Yeah.
One thing you can do, immediately introduce everywhere. People get a choice, they get 1 ringgit card. At least it's more significant than 10 cents.
Definitely, yeah, definitely. Now, I want to go into another area first because another issue that KKM has brought up, and this has been a long-standing issue, is the manpower shortages in public care. Especially now, I was surprised to hear that now even doctors are in short supply, MOs and all. But I won't touch doctors first. We'll go into that in a while. But the long-standing problem is nurses. Nurses in Malaysia, hospitals are facing shortage of nurses. I've spoken to many doctors who have told me, there's many cases of nurses on drips and doing their work because they have to stay awake for long hours. Why can't we solve this nurse shortage problem?
I think this is a chicken egg story. So when we look at the nurses shortage, one is look at what they are paid. One, whether there's enough institutions to churn out more nurses. The answer is yes. So many. But what happens is they are offered a better offer overseas, triple the salary or quadruple the salary. They move to the Gulf, they move to Singapore, they can move to Australia. So they're moving out because what they're getting. I've seen like one nurse who I used to see her at one of the clinics where I used to practice. And at that point, it was I think like about 10 or 15 years ago, when I was just a junior a medical officer. And then when I saw her back recently in one of the private hospitals, and I said, like, how long have you been working here? She said, like, I've been working almost 8 years already, doctor. And she said, like, no, I want to leave. Then I just asked out of curiosity, like, why you want to leave? It's so nearby your house and everything. And she said, like, do you want to know what's my salary here? 2,200 after reduction of EPF.
My goodness.
And it was in a private hospital. It's a well-known private hospital. Then I asked her, like, really? I said, yeah. Of course, I only work 9 to 5 because I manage the clinic, but that's what I was getting. So then makes me feel like, okay, look, maybe all of these nurses wanted to get into government service because the increment or the system or the tangga gaji and thing, there's perpetually some form of increment, at least 100 ringgit, 200 ringgit on an annual basis. And
It's not
scenario.
happening.
So what happened? So you're gonna have this, and that's why you realize that I think last year or so, the previous minister was put into hot waters when she accidentally said, like, yeah, we're gonna consider getting nurses from Philippines. Because the private hospital associations were telling them, look, we're short of staff and we've got to get staff from somewhere. So what's the way to get? If I'm going to pull staff from MOH and offer them double or something, that system gets stuck. The only option they can think about is
Philippines.
Look outside of the borders and get. I don't know whether that thing kicked off or not. I think it didn't kick off. It didn't kick in straight.
But if the salary of nurses and doctors are so low, especially in public care, and your example was private as well. You just mentioned private, right? Then if you are talking at like IGN requesting to increase by 40%, if you are talking about private hospitals charging so much for healthcare, where is this money going to then?
Good question. Very, very good question. To the owners, like, yes. So when you touch that,
Is the healthcare industry so corrupt? I mean, that doesn't sound like very nice industry.
Very corrupt.
Very corrupt. Okay.
Healthcare is very corrupt. When you talk about doctors, to to say. When I think 2018, 2019, the amount of housements coming in was an average about 6,000.
6 to 7 per year.
Yeah.
So just
Now-
before that, since you're
Yeah.
going on that part, I just want to read this
Yeah.
so people will know. So basically, the number of graduates, medical graduates, have steadily declined since 2018. To quote Health Minister Datuk Sri Dr. Zulkifli Ahmad, he says, the country at one point had 6 to 7,000 medical graduates per year. Currently, the figures have dropped to 3,000 annually. And just another point as well, according to the MMA, Malaysian Medical Association, fewer Malaysians are signing up to study medicine due to several factors, including contract issues, burnout, lack of permanent positions in public healthcare system, and bullying. But yes.
Yep. So I think the minister is spot on. I wanted to mention the same numbers. Yeah, 6,000 to 3,000. That's a 50% drop, and I think it's going to drop even further. I think a lot of us who were in, let's just say like me, I've been in practice 16 years already. So when I was a houseman in 2008, okay, we had this bullying issue. We had this kind of seniors who are a bit rangi, I call it, and the specialist will give you hell, and you will be awake for 36 hours to do an on call. It doesn't happen now, but that bullying culture still exists. The bullying culture still exists, and that has to stop. I mean, like senior doctors, maybe in maybe my age, many of my friends are specialists and everything, whether in private or in government. I think that kind of way and handling our juniors should end. Should really end. I think the Gen Z, Gen Y kids,
They can't really take that.
They can't really take that.
Yeah, it's not
and we're going to lose a lot of talent. See, if you lose the talents, are you going to lose the talents today to AI or robots? Of course, they're going to come. You cannot deny that. We don't have nurse soon. AI will be our nurse, or a robot from Elon Musk, Tesla.
Tesla's new one.
will be serving you your medication and checking your BP in the
Doing
clinic.
your, insertion.
Cannulation.
Yeah, and all that. No, but interesting you talked about that, because I want to get to that. Now, of course, recently, 2 members of the board of visitors of Putrajaya Hospital said that the tragic death of Ladatu specialist Dr. Teh Tian Ya from suicide is not an isolated incident. So they are agreeing with you. They are saying that that it reflects a long-term workplace bullying culture that's been taking place in Malaysia's healthcare system. Now, in your opinion, why hasn't KKM done anything to address this matter? Because what people are saying is that the death of Dr. Teh Tian Ya has actually opened up the hatchet and revealed what is actually happening. Why haven't they done anything?
I think I will look at it as a 2 perspectives. One, these are pocket events that are happening. We had the issues with Sungai Buloh about sexual harassment just a couple of years ago. We had this, unfortunately, a specialist, in fact, and it goes around. I mean, if you look at certain porters, like the junior porters like Hartal Doctor and everything, where we're not getting their contracts and things, one issue. So one is the stress level. So if you have too many patients in a pipeline, okay, the pressure always goes down to the low end.
Okay.
The pressure goes down to the MOs, the pressure goes down to the house officers and stuff. Because you see, the specialist will come at the round and he will call the hard calls, but he's not there handling the volume. He's going to come at 8 o'clock after the MOs, the HOs do their first round, the medical officers do the round, and then comes the specialist. And then with the specialist comes maybe head of department, maybe let's say head of department or surgery or thing. Okay.
Yeah.
His interest as a specialist now will go now to do 2 things. One, he might be the ketua jabatan at that clinic, that hospital. Another one thing, he might be busy for surgery. So the number of volume that comes into the pipeline is not his problem. You say that I'm not sleeping at night, 3 o'clock clocking the case. If there's a surgery and I'm on call, then I'm coming in to do the surgery. And that's it. The other things are already all mitigated. But sometimes when there's so much of volume, there's a possibility of error. The quality might be compromised. So sometimes when it gets up to their level, it's like, how come you missed this? How come you missed this blood test? How come you missed that? So sometimes there's a lot of frustration when things doesn't go smoothly.
Okay.
So the emotional frustration of handling too much or chewing too much sometimes happens. And then if there's a problem, he gets called up to the hospital director. hospital director gets called up to the state director. So it's always like this. So by the time the problem goes up, it just goes up. So again, I still feel the biggest issue here is when they are stressed and underpowered, things go out of hand. And here we're not talking about a factory time bell or electrical shortage. We're talking about lives there.
But just on that point, because there is a saying, right? Pressure either makes diamonds or it bursts pipes. If I give you another example, if you look at Malaysian badminton, for instance, you look at the previous our great Dato' Miss Munside, and I do mean great, I really sincerely do. He's the one who introduced Lee Chong Wei. He even brought current player, what's his name, Lisa Jia from 100 to world number 10. His methods are tough love, hardcore training, like what we used to see in movies like Rocky and all that kind of training, right? That's the way he does it. Does this system of, I wouldn't say it's bullying, but this aggressive sort of teaching by tough love kind of approach,
Spare the rod,
spoil the child, right? Is that kind of approach results in better doctors, in your opinion? Because you went through that.
Yeah.
And removing this, will it result in a drop in quality of the doctors that are serving in hospitals?
It's a yes and no, I would say. But I think it has not to go to a point of bullying. Because I have seen when I was...
No, but to be fair,
I mean,
you got the same harassment.
As,
right?
as a junior doctor, there are things that you do not know sometimes. There are things that you can get wrong. But sometimes you need to be reprimanded, and sometimes it sticks, it burns you, until today. Like certain incidents that you have seen, your friends get it, or you get verbally abused in front of a patient. Then you feel like, oh my God, why am I even here like that? Why after all these years of studying, you get insulted like this, like right in front of the patient. And that also creates like the distrust of the patient. Like, really, this guy's going to take your blood? Really, this guy's going to prescribe your medication? So you feel insulted, but not everybody can get it. A person like me, I'm like Russian trained. I will go all out. If you see what I do online, I'll go all out for what I want to win. But it's not everybody's going to be like that. I cannot expect every single house officer, MO, or even specialist to have that mentality. You're talking about, just give a scenario of, these guys are like military. Are you expecting a private to be like a SWAT guy?
But,
no, right?
But what you're talking about is a natural filtration system. So, which brings another point. You survived it. You had been a doctor for 15, 16 years, right? You survived it. You're now a very successful doctor. So, what I'm saying is that this system, I'm asking you, is that this system, does it weed out those who can't? Or and instead allows the cream to rise to the top? Because not everybody can be a doctor. And perhaps this mental fortitude and this sort of like attitudes that you are talking, like going full on, gung-ho, wanting to complete a task regardless of the consequence kind of thing, wanting to get an answer, isn't that required? And
it is required, but you see, to a point of when you are suffering from a burnout, now this becomes a problem. Because you are overworked. But that somehow has been sorted, I would say. I mean, the juniors today don't work 36 hours like what we used to go, like handling 2 wards, juggling, and then deciding who lives tonight with like 3 fellas down, and you have to decide like, who will do CPR tonight. That has happened in my time. Okay. And today there's more people in the ward. At our time, there was like one person, you handle 2 wards. That means there's 50 people. Technically, you are the only solo guy running the solo flight from 5 o'clock in the evening until tomorrow when your friends come in. Like, it was like Doctor Strange just opened the portal, all the friends are back at 7 o'clock in the morning. But today there's more. Okay, but like I said, the bullying issue, the verbal abuse, respecting your peer, even though you are senior by 20, 30 years. Because at one point, you were just like them. Of course, like today, if I can see a blood report, I probably take like 10 seconds, chop. I know what to do. But if I was to throw the same thing to a doctor who's like just came out 1 year ago, or now at housemanship, maybe 1 or 2 departments, tell me what's the diagnosis, or look at this guy and tell. They will make mistakes. They will, but you see, with that comes learning one. That's why it's called practice. But there's also a filtering system where you have an MO. You have an MO behind you to manage that 20 cluster or 10 cluster of housemen.
Okay.
You have a specialist. Some situations, some hospitals have even super specialist consultants and stuff like that. So there is certain form of QC going on
Consistently.
consistently.
Okay.
So that's fantastic. But when it comes to verbal abuse, respecting your peers, I think this is the thing that we cannot take that stress and just like throw it to our juniors or throw it to another individual.
Okay. Another point that I've read is that many doctors, not many doctors, but there have been doctors who've been voicing out in certain articles, remaining anonymous doing so. I think there's an article on Channel News Asia as well, where they talk about how because of this workforce shortage that they're facing in hospitals, doctors and nurses, doctors are now having to do administrative tasks as well. So do you think that the shortage in workforce is also contributing to the stress levels of the senior doctors and why they are taking out on the juniors?
I don't know about the administrative tasks, but usually once you climb up the hierarchy, you have a lot of administrative duties.
Okay.
In especially public service. Private service means if you're a surgeon, you just stay a surgeon until you die.
Okay.
But private service, government service, yes, you go into a lot of administrators. So it means like you can be promoted to a senior role in the hospital, or you will take like certain other duties in state level and stuff, or you can even be promoted to a director general or as deputy director and stuff like that. So yes, they transit a lot into, and then the transition takes maybe in your 40s you're already going into those roles kind of thing. So some people maybe have to do a by role. They do a lot of clinical work at the same time they have to do administrative duties. This is what I saw that in America and other states, they are hospital administrators. They come in to do you stay a surgeon, you do that, you do best.
Which is the best way actually.
Exactly. Yeah. There was one point of my time that I actually wrote to my department and say I want to move after completing my masters to move to economic planning unit.
Why?
Because I felt at that point, whatever I think I was able to do was not there. I think we need to look at people who are able to see budgets, people to see the economic side of healthcare. There are health financing systems established in KKM, but who's going to issue out the budget at the end of the day? Everything goes out to MOF. Everything goes out to the EPU and being sent back. But so if there are people there who are only focused on administration, that's a problem. If there are people there who don't understand clinical perspective, that's another problem. So we see this disparity today, and we see clinical issues happening in hospital and public healthcare experts seeing numbers. They are not in practice. So they're not seeing the ground what's happening. So we need this sort of this dance or balance between both of these to actually see people who understand economics, who understand the economic infrastructure for healthcare, and also people who need to see real patients. What are we seeing? What trends are we seeing on the ground?
So do you think that one way to solve the manpower shortages definitely is automation? You see this now.
One definitely.
But are we doing enough in terms of that? Because, for example, let me give you an example. When you go into a clinic or a hospital, they check your blood pressure, they check your temperature and all that, which can so easily be done by devices today, right? But you don't see those devices now. So is this in terms of automation involving AI and all these new technologies, are they doing enough?
No, not yet.
Not yet.
That will soon come.
Okay, well, that's good. Now, I want to go into another topic.
The only thing is whether you're going to trust a robot.
Yeah, Elon Musk
That's
robot.
going to be the last one.
Yeah, putting a thermometer in your mouth and Okay, so another topic of contention is definitely the pay of doctors. So just to put some context again, the per hour salary of a Malaysian part-time worker is 12 ringgit 78 cents. Now, the on-call allowance rate is for doctors working in government hospitals has been stated to be 9 ringgit and 16 cents
per hour.
Per hour for a 24-hour weekend on call. So why is the doctors and obviously some people have pointed the pay structure to be a reason why they leave this line.
And also the contracts now.
Contracts and all that. But why do you think, again, this disparity in payment has not been addressed?
Because they can choose not to address. That's all.
That's
Because it's very simple. Because you see, when you join in as a practitioner or pharmacist, I think it's not just us. It's other professionals also around in the medical system. You have a mandatory service. My time it was 5 years. Currently, it's only 2 years.
Okay.
Okay. So why 5 years is because they knew they got to juice us as much as they can.
Okay.
Okay, that's one thing. Okay, then let's just say if I chose to go into specialization, then I'll be now trapped into maybe if I'm a JPA scholar and think I get another 10 years slap. So I'm in the system for the next 14, 15 years. So when I'm in the situation, can I say anything?
No, of course not.
No.
Can't,
So
yeah.
that's the answer.
Yeah.
So now, and in this 2018, 2019, 2021, we saw that there was this surge of practitioners. That created another problem. Now, where do we distribute them?
Yeah.
And whether JPA got enough fund to pay everybody. So what was the option is, let's choose who we want and let go who we don't want. So that unfortunately happened at that point. So that came that contract position. So those people who felt like, I don't mind staying in the service because I enjoy the service, I enjoy the perks, and I'm willing to do that 8 ringgit. So be it. Willing buyer, willing seller at that position because I get pension, I get this, I get that. But when came the contract now, there were a lot of people now in limbo. What happens next week when my contract gets exhausted? Do I get retained in the system? Because if I don't get retained in the system, then I have to leave. When I leave, I'm being assassinated of my career. Because let's just say I want to be an ophthalmologist. Then I don't get sent there and I don't get a contract renewed. So I do not mature into an MO or hopefully going towards being an MO in an ophthalmology department. And then maybe I sit there for 1 or 2 years, gain some experience, and then they say, let me apply for a master's program in the system because maybe I don't have options to go overseas and do the master's. So now I'm stuck in the system. It's almost like a clamp on your leg. So when they don't get that, now they're stuck. Okay, if they leave, what's the option? You be a GP, or maybe be an influencer on TikTok, or sell products, or become a founder, or become this. So that's another spin-off that a lot of young doctors, if you see online, they're doing so well. They are not going to establish a practice. They are just happily selling products online, and I can't blame them. One thing is maybe they're giving some form of decent healthcare education to public. If you are a pretty face, you can create a serum or a product or a collagen and stuff. Maybe get it registered with the NOT, which only take like 10 days to get registered. Or maybe you have a consumer product, a food grade. Maybe another 21 days you get it registered. Or if you really want to go for the high flying like MAL notification, you wait for 1 year to get it registered. If you come from a rich mom and dad background, you probably have already like cash capital injection of like maybe 500K. Rather than opening a clinic, look, I'll invest into this product. And let's look at this picture now. I'll spin the table and tell you what's happening in the system. I'm still going to be a clinician, don't worry. Let's just say you go on TikTok or Shopee and sell 5 products.
Okay.
And let's just say you make, let's just say maybe 50 ringgit on each product, 50% margin. No need to open a center and everything. All you need is a nice studio at home, and you do it twice a day. Technically, you're online like 4 hours a day, and you sold like 10 boxes. That's 500 ringgit.
Yeah.
500 ringgit times just being online for 20 days. That's 10,000 ringgit. Let's say you pay your tax and everything. Do you think this junior doctor is going to earn any of this in year 3 or year 4 working in
definitely.
in a private GP doing locum or working in the system?
I mean, for the hours, no, definitely
No.
not.
So then they will tell you, look, I rather build my brand now. I will go for certain trainings. I'll go for some finance training. I'll go for some marketing trainings and grow myself to it. So what if I don't see patients today? I have already got a DR title from one of the universities that gave me. Nobody can take that away from me. The public still have a lot of respect for the title.
Which brings an interesting point because you being a seasoned practitioner, do you think that the standard of doctors today are much lower than when you came up?
I don't want to say that. I think it's disrespectful for us to say that because I feel that junior doctors or medical students today have access to maybe the greatest lectures available online. I would say during our period, there was no YouTube.
Yeah.
You are as smart as your medical library in your university.
Yes.
And that's it. But today maybe the ways medical education has been taught, lectures online. So if you're not even comfortable with your lecturer, you're still not getting it. There's abundance of knowledge for you to acquire, and with technology, there's ability to learn from others, and it's just not like your clinical practice guideline. There's a way, so many ways of thinking, so many opinions, and so I think they are going to see medicine in a very different way compared to maybe my seniors. They're going to see it different, and I think that they are more receptive. They're more receptive of new thoughts, new viewpoints, and we've got like limitless journals to access to. So it's going to be different. So like we have a challenge with our seniors today, because some of them are still very rigid with the old way of thinking of therapy and preventive medicine and stuff. So I don't think so that they're going to come in short-handed. I think they're going to actually move medicine into new dynamics, because like I said, look, they can do education online, even though they are selling products. But if they get the core issues right, then it's fantastic. But the issue will have is now how many surgeons will be able to churn in the future? How many people are there to sort of like replace? It's like a population replacement. No? Like how many people are coming into the pipeline to replace the ones that are leaving the system? Because maybe you wouldn't expect someone at 75 to perform surgery at the moment and sit for 7 hours to do some bypass surgery. He's not able to. Maybe his hands are already rattling.
Yeah.
So you got to have younger people coming
to replace him.
Yeah.
Right?
So it's not always about, we have to have the issue of replacement, one, and also looking into the point of when these juniors leave the system. Now, how many younger ones are coming in? These seniors leaving the system, how many people are able to replace? Because if there's so much of demand in private facilities, offering them 10-folds, 5-folds of the fee that they would get, why wouldn't they leave?
No, that's true. That's true. But before we go into the next part of this interview, I think this is a pretty subjective question, lah. But it's because we are both Indian, so in our culture, doctors are worshipped. You are idolized. You are the goal. Right, which is fair, which is fine, because I always considered a doctor to be a noble profession, because come on, you're dealing with human life. How more noble can you get? And so that's why I asked that question, because I think that when I was studying, I remember that was the sort of like what happened during my uncle's time when he was in uni, where computer science was like the course everybody wanted to go. If you go for any university graduation, you'll see computer science will take 1-2 days for all the graduates to come out. Same thing with medicine. A lot of medical universities were popping up in Malaysia until they stopped giving license, thank God. And then after that, every parent wanted their child to be medicine, especially Indians, right? So I just want to get your opinion, being a doctor. Do you think medicine is for everyone? Or anyone who can achieve it based on grades, or should there be another criteria to assess whether can a person become a doctor?
Wow, this is a tough question. I think